Well, welcome everybody to this month's version of our Bending the Climate Curve lecture series. We will get started in just about 30 seconds. Great, if you're just joining, we'll get started in about 10 seconds. Well, good morning everybody and welcome to the latest installment of Mazzetti's Bending the Climate Curve lecture series. My name is Troy Savage. I'm a manager of strategic projects and innovation at Mazzetti, where bending the climate curve is our mission. Before we get started, just a bit of housekeeping. Today's event qualifies for one AIA CEU. If you didn't provide your AIA number when registering, please send it to info@mazzetti.com. Today's session will address these 4 learning objectives. The way we usually do this is we'll hold questions until after today's speakers have made their presentations, but you can submit your questions at any time via the Q&A function of the webinar. Also, today's session is being recorded. So now I'm pleased to introduce Sadat Khan. He's an energy engineer at Stanford Health Care. He has done a great job of helping the organization to decarbonize its Scope 1 and Scope 2 portfolio while maintaining quality and resilience of service. He holds a Master of Engineering in Mechanical Engineering and has strong professional interests in energy efficiency, capital asset improvements, sustainable design and construction, life cycle cost assessments, emissions reductions through leading operational change and organizational change management. We're also welcoming today Praveen Kalra. He's an anesthesiologist at Stanford Medicine. He's board certified in both anesthesia and in critical care. He was appointed Fellow of the American Society of Anesthesiology in 2023, appointed Medical Director of Sustainability for Stanford Health Care in December of 2023. His professional interests include reducing the impact of anesthetics on the environment, therefore addressing climate change by reducing greenhouse gas emissions in the healthcare setting. He's been in practice for over 19 years. And without further ado, I turn it over to our speakers.
Good morning, everyone. My name is Praveen Kalra. Thank you, Troy, for the introduction. Sadat, you will have to move the slides. So today's our topic is going to talk about nitrous oxide is also called as laughing gas, and laughing gas is actually not a laughing matter anymore. And we are going to show you in the next 60 minutes how by utilizing the slicer dicer tool on our electronic medical record, we were able to slice down our greenhouse gas emissions coming from our ORs. Next slide, please. We already talked about nitrous oxide. This is an inhaled anesthetic which has a global warming potential of around 265, and it was representing around 25% of Stanford Healthcare carbon footprint from Scope 1 emissions. It is either delivered either through a centrally piped system from a tank farm, or it can be delivered through portable cylinders which are available at the back of each machines. At Stanford Health Care, we have been using centralized pipe systems at all the applicable buildings. And I'm going to share some data of our own pilot study, but even case studies done at other health institutions were able to show that 90% of the pipe nitrous is lost, never delivered on patient care. While if we are using nitrous oxide through portable e-cylinders, there can be extremely minimal leakages in that system. So this session is going to show you our journey towards sustainability, how we were able to decommission nitrous oxide at 2 of our facilities, and we are happy to share those some challenges and lessons what we learned throughout this journey or process. Next slide, please. So Stanford Medicine has an extensive, huge healthcare carbon footprint in the Bay Area. It has almost 80 plus Bay Area locations. But for the purpose of this talk today, we are going to focus on 4 buildings. Stanford 500 Pastures Drive, which is our main hospital and one of the latest hospital. Standard 300P Pastures Drive. Then we have an ambulatory surgery center at Lane Wilbur Street, as well as Redwood City of pilot locations. So these are the 4 locations we are going to talk about from decommissioning of nitrous oxide. Next slide, please. Stanford Health Care actually committed to address its greenhouse gas emissions by implementing a robust program to monitor these emissions on an annual basis. In 2022, Stanford Healthcare leadership signed a Human and Health Services pledge at the White House, and they actually committed to and prioritized to measuring 5 targets from sustainability to reduce their greenhouse gas emissions coming from its carbon footprint from healthcare, reduce their energy use intensity, reduce their water use intensity, also prevent the waste going into the landfill, and addressing chemicals of concern. Now, after they made these 5 commitments, they basically came up with some extensive targets which they felt we have to meet in the next decade or so. So those targets were reducing our scope 1 and scope 2 emissions by almost 50% by 2030 when we compare ourselves from 2012 as a baseline. Reducing our energy use intensity by 25% as compared to our 2022 baseline when we signed that pledge, with our eventual goal of net zero emissions from scope 1, scope 2, and scope 3 by 2050. So these are the 3 big ambitious goals which Stanford Healthcare decided to implement and started working on that. Next slide, please. This is one of the best graphs which actually shows our journey of how where we are at the present moment. So this graph actually shows a very clear distribution of the role of greenhouse gas emissions coming from energy, from natural gas, as well as from medical gases in 2012. So our cumulative carbon footprint from scope 1 emissions was roughly around 38,000 metric tons. In order for us to reach 50% goal, which means around 19,000 metric tons, you can see a horizontal dotted line. That is our goal. That is where we have to reach. Now, Stanford Healthcare made huge strides by decommissioning their cogen steam plant, as well as also getting electricity from a city of Palo Alto, which provides electricity to Stanford Healthcare by renewable sources. So they made tremendous strides in reducing their carbon footprint as we move on from 2012 to almost 2016. Now coming back to medical gases were responsible for around 11% of our main Palo Alto campus Stanford Healthcare carbon footprint in 2012. And medical gases were responsible for roughly around 2% of our carbon footprint at the Redwood City campus. As you can see, and medical gases are shown in the orange line, you can see that the medical gases carbon footprint is actually increasing. It was 11% in 2012, and it went up to almost 25% in 2022. So in spite of the fact we have reduced our carbon emissions by 36% since 2012 levels, this is why nitrous oxide became a priority for Stanford Healthcare, that in order for them to accomplish 50% reduction in their scope 1 and scope emissions, they have to address nitrous oxide. That is where it became a priority, and that's where nitrous oxide fit into the bigger picture of Stanford Healthcare carbon footprint. Next slide, please. So broadly speaking, anytime when we talk about greenhouse gas emissions coming from healthcare, we typically divide them into 3 categories: scope 1, 2, and 3. Scope 1 emissions are coming from the facility itself, like the direct emissions. And under these comes, of course, natural gas, electricity that is being consumed. Medical gases also comes under scope 1 emissions. And for a typical healthcare facility, scope 1 emissions are roughly around 17% of the carbon footprint. Scope 2 emissions means how that electricity is being purchased. Is it coming from renewable sources or is it coming from disposable sources like coal, natural gas? So that for any typical healthcare institution could be around 10 to 11% of the carbon footprint. Bulk of our carbon emissions comes from scope 3, which includes pharmaceuticals, which includes medical devices, food, employee commute, amount of the waste generated. So the bulk of emissions, almost like 71% comes from scope 3. So for the purpose of discussion today, we are going to focus our attention on scope 1 emissions. Next slide, please. So Practice Green Health provides us some sort of a report card of how Stanford Healthcare is doing from carbon emissions. So in the fiscal year 2023, our cumulative carbon footprint was roughly around 424,000 metric tons. But if we look at scope 1 emissions, our scope 1 emissions are roughly around 20,000 metric tons. The biggest driver of our scope 1 emissions were natural gas and electricity, almost 70% of that, 14,000 metric tons. And the next biggest contributor to our scope 1 emissions were medical gases, almost 5,236 metric tons. Next slide, please. Talking a little bit briefly about nitrous oxide. So typically in clinical practice, there are 4 types of anesthetic gases which we use. 3 of them are fluorinated anesthetic agents: desflurane, sevoflurane, and isoflurane. They are actually available as liquids in a bottle, which we are putting it in a vaporizer, and it is going in addition with our carrier gases, oxygen and air, to our patients to induce anesthetics. Nitrous oxide, on the other side, is an extremely weak, odorless, colorless gas. Since you have to understand 3 properties from an anesthetic point of view. First of all is their potency. Potency is determined by their MAC value. Higher the MAC value, lower the potency. And as we can see, the nitrous oxide MAC value is greater than 100%, meaning it is extremely weak gas. It is never used as a primary anesthetic agent. It is always used as an adjunct to other anesthetic gases or in combination with intravenous anesthetic agents. The second property we have to talk about is how it is impacted in the environment, meaning its global warming potential. It is 265 times more potent than carbon dioxide. And the third property is for how long it is going to stay in that environment. And that number is roughly around almost a century. So any nitrous oxide which I use today, tomorrow, is going to outlive me because it's going to stay there for more than a century. Next slide, please. Since nitrous oxide is a weak anesthetic agent, it has to be used in higher volumes to induce anesthetics. And that's why the way to deliver nitrous oxide to a hospital is either through a cryogenic tank systems, or through compressed H cylinders, or through portable E cylinders which are available at the back of each machines. Now, each of these comes with some unique set of challenges. The cryogenic tank systems and compressed H cylinders are generally available or present at the basement of the hospitals or outside the hospitals. And the only way to deliver nitrous oxide to our operating rooms is through the pipelines. There is a massive network of pipelines that deliver nitrous oxide from these tanks and cylinders, big cylinders, to our operating rooms. And that is where the chances of leakages starts happening. Next slide, please. So I'm going to quote this study from Dr. Brian Cheesebro and Andy Mason at Providence St. Vincent Medical Center study. So there is extremely a very high loss rate for nitrous oxide when it is being delivered through a centrally piped system. And the way they conducted this study is by measuring the purchasing data and comparing it with their clinical data of how much nitrous oxide is used. So when on the graph on the left-hand side is the way when a central cryogenic tank system was used, comparing again the purchasing data with the clinical data, almost 2 liters of nitrous oxide was leaking per minute. And the reason being, cryogenic tank systems store nitrous oxide as a compressed liquefied gas. The liquefied gas is liquid is converted into gas. Therefore, it increases extensive amount of pressure within the tank system. And there are safety mechanisms already inbuilt in the tank system, sort of relief valve. They vent out that nitrous oxide whenever that pressure starts building up. Also, it is considered as a normal practice of normal evaporation rate of 0.8 to 3% with cryogenic tank systems, meaning that a tank can lose up to 0.8 to 3% of their nitrous oxide volume on a daily basis, and that is considered as a normal operations as a part of our inbuilt safety mechanisms. Generally, these tanks are provided in pairs, primary cylinder providing nitrous oxide and the secondary cylinder always used as a backup when the first cylinder runs out. So the secondary cylinder could also be losing around 0.8 to 3% of the nitrous oxide on a daily basis. So at the end of 30 days, presuming if that's the lifespan or the time when the nitrous oxide starts running out from the primary cylinders, there's a very good possibility the secondary cylinder could also be almost half empty by that time without any nitrous oxide used on clinical care. Now, the second solution could be providing nitrous oxide through compressed H-gas cylinders. As you can see in the graph in the middle, that by doing so, again comparing the purchasing data from the clinical data, they were able to show that the nitrous oxide leakages were reduced by almost 2/3 from 2 liters per minute to around 650 cc's per minute. Still a lot of leakages, and this leakage is happening because of the vast network of swathe of all these pipelines that are being traveling through the hospitals to deliver nitrous oxide into the ORs. On the right-hand side is a graph about portable E-cylinders, which are small E-type of cylinders available at the back of each machines. And you can deliver nitrous oxide directly to your machine with very minimal amount of pipeline needed to do so. And that actually reduces the leakage almost to zero. Next slide, please. These are some of the sites from where the leakages happens, as the graph in the middle shows a relief valve of a central cryogenic tank system from where leakages were happening. Leakages were detected at the wall, ceiling outlet, at many other locations. It is extremely difficult to do extensive testing of all these leakages. First of all, the test is qualitative. Second of all, it can detect leakages at every location. As you can see, the graph on the extreme right hand side is a vast network of pipelines. And nitrous oxide by itself is a very cheap anesthetic gas. It doesn't cost a lot, but to conduct an extensive test, the test is far more expensive. So you have to start looking into that. If the test is more expensive than the product in itself, is it worth spending that much amount of time in trying to figure out the leaks? And even if we find the leaks today, we can fix it today. There is no guarantee that those leaks cannot happen at some other location on a different day. Next slide, please. So again, we went back to our practice green health data and we looked at it. We knew that around 5,200 metric tons of carbon emissions are coming from our medical gases. We wanted to quantify those carbon emissions. How much of that are coming from nitrous oxide? And almost 4,485 metric tons were coming from nitrous oxide and very little bit from other anesthetic gases like desflurane, sevoflurane, and isoflurane. Next slide, please. So looking at the data, we've realized that 93% of our carbon emissions are coming from nitrous oxide. We have already removed desflurane from our operating rooms almost 5 years ago. And by replacing desflurane, which is another anesthetic gas which has the global warming potential almost 10 times higher than nitrous oxide. When we removed that anesthetic gas from our operating rooms, our team was able to eliminate 434 tons of greenhouse gas emissions, which is almost equivalent to driving 1.1 million vehicle miles savings. Next slide, please. So we took the next step by using slicer dicer to look at where are we using nitrous oxide. So for the purpose of reference of these 4 hospitals, 500 P Pastures Drive is our latest hospital. It has almost 40 plus operating rooms. 59% of nitrous was being used in that hospital. No surprises there. 300 Pastures Drive, the second biggest hospital, was using around 19%. Our Blake Wilberg ASC Center was using around 16% and Redwood City around 6% or so. So we now knew that we could quantify how much nitrous is being used where, and then we had to started thinking about how to conduct a pilot and what will be our goals of the pilot study. Next slide, please. So we followed the same principles we looked at the purchasing data. We wanted to prove it to ourselves. The studies that have been done at other hospitals showing that in a central cryogenic tank system, if 2 liters of nitrous is being lost on a day, on a minute basis, and even with compressed H cylinders, if 650 cc's of nitrous is being using, and Stanford Health Care uses these centralized systems to deliver nitrous oxide, is it really true in our setup that we are also losing 90% of nitrous oxide? So we collected the purchase data. Now purchasing data, Airgas and Linde are the two vendors that provide nitrous oxide. Nitrous oxide is delivered in pounds, and pounds are converted into volumes. So the way to convert weight into volume is 1 pound of nitrous oxide almost equates to around 247 liters of nitrous oxide. We purchased around 38,000 pounds of nitrous in 1 year, fiscal year 2022. And when you multiply that by 247, it comes out to be around 8.2 million liters of nitrous oxide. We went back into our EPIC data to look at how much nitrous oxide is being actually given to our patients. And that number was 780,000 liters. This proved the first fact of the equation that yes, we are using less than 10% of nitrous oxide on our patient care. More than 90% is leaking from the system, thus proving that the pilots that have been done at other hospitals are indeed true, and the results are verifying in our setup as well. Nitrous oxide is a very cheap anesthetic gas. You can see it only costs our institution around $63,000. We went one step further. We wanted to see which surgical clinical specialties are using the highest volume of nitrous oxide. So orthopedic services, general surgery, and neurosurgery were the 3 largest users of nitrous oxide on the campus. Based on this data, next slide please, we decided to conduct a pilot study. So we chose Redwood City as our first pilot site for a couple of reasons. Number one being it is a small hospital with 8 operating rooms. Majority of the cases done there are orthopedic surgeries, which is by definition one of the largest users of nitrous oxide. So we wanted to control all aspects of it in terms of data collection. And if we find the results here, is it easy to scale it up at other locations as well? So we chose Redwood City as a pilot study. Next slide, please. And over a 1 month period, we decided to conduct this pilot. Before we started the pilot, we sent multiple reminders and educational materials to our healthcare providers, to our anesthesia technicians, to make sure there is a buy-in from all the stakeholders. What we did was we decided to disconnect our pipelines from the wall outlets. So the only way to deliver nitrous oxide is through portable e-cylinders, which are available at the back of each machine. We started weighing these cylinders on a weekly basis because we know that how much nitrous is going to be coming out of these cylinders. If we can weigh these cylinders, we can calculate the volume of how much nitrous exited these cylinders. We provided no restrictions at all on any of our healthcare providers of how much nitrous they want to use. They can use as much as they want. We just asked them only 2 things. Number one, if they want to use nitrous on their patients, they simply have to turn on the key, which is connected to our portable e-cylinders to start using nitrous. At the end of the day, we made the responsibility of our anesthesia technicians to turn off these cylinders, so that way there is no leakages of nitrous oxide happening during the non-use hours. So over a span of 5 weeks or 4 to 5 weeks, we calculated that around 7.5 pounds of nitrous left those cylinders, which you multiply with 247, it came out to be around 1,695 liters. We went back again to look at how much nitrous was delivered to our patient, and to our surprise, more nitrous was given to our patients than actually what came out of those cylinders. And this actually really puzzled us, that how can that be possible? The difference, even though is only 144 liters, and which is literally almost half a pound of nitrous in 8 hours over 5 weeks period. And the reason this error was happening was because our weighing machine has some limitations in measuring the weights of these cylinders. They cannot measure anything below 1/10 of a pound. So because of that, we could actually prove 2 things, that whatever nitrous that came out of those cylinders was completely given to our patients, number one. Over a span of 4 to 5 weeks, only 1 cylinder needed to be replaced. This also helped us in analyzing that there won't be any supply chain issues. It will not increase the work of our anesthesia technicians, and almost all nitrous oxide can be delivered to our patients, and that was the objective of this pilot. Next slide, please. So I'm going to go back to the same slide which I showed you earlier, showing our carbon footprint from Scope 1 emissions. So we believe that by decommissioning our nitrous oxide, we will be able to reach our 50% goal reduction in our Scope 1 emissions by 2030, almost by next year, 2025, almost 5 years ahead of the plan. And that's why nitrous oxide is our main trump card to reach us to that goal, just because of the carbon footprint nitrous oxide has. Medical gases are 25% of our carbon footprint. 93% of that carbon footprint is coming from nitrous oxide. 90% of the nitrous oxide is leaking from our systems. If we can control that 90% leakage problem of nitrous oxide, we can significantly reduce our carbon footprint from nitrous oxide, and that will dramatically reduce down our net Scope 1 emissions carbon footprint. Next slide, please. I'm going to hand it over to Sadat. He is going to take you through how to get the buy-in from stakeholders, regulatory compliance, as well as other lessons what we learned from this project. Over to you, Sadat. Thank you so much.
Thank you, Dr. Kalra. I hope everyone can hear me okay. My name is Sadat. I'm the energy engineer with the sustainability team at Stanford Health Care, and I work very closely with the facilities operations team, as well as with our sustainability partners, including Dr. Kalra himself as well. And before I dive into the project structure and process for nitrous oxide, I would just like to say that as an engineer, when I came across this opportunity about a year and a half ago, I was mind blown by the amount of leakage that case studies and data was showing for nitrous oxide in the centralized delivery system. And so when Dr. Kalra and I started talking about this about a year and a half ago, and learning from a lot of the case studies from Providence, and I would like to recognize their leadership with Dr. Cheeseborough in this area. It really drove home the point of looking at our operations in the healthcare setting with a little bit more closer detail, and reevaluating: do we need the systems that we have today in place, or do we need to move towards more efficient methods of maintaining the same operational quality that we have in our healthcare settings? And so these next couple of slides, I will focus on how do we actually turn this then into a project. You've identified the opportunity. You've looked at, well, this is something that I need to do. How do we as in an organization, in a large organization, how do we then turn it into a project? How do we go about implementing that? So at a very high level, the project structure needs to be set up that it is a close collaboration across the OR team, the anesthesia team, facilities or sustainability, and biomed, all with a primary focus on ensuring patient safety. Those are the key stakeholders that need to be involved, including, and as we were starting off, we involved other stakeholders as needed into the process, which included our regulatory team, our infection prevention and control team, our environmental services, environmental health and safety were pulled in. But the primary drivers for how this project gets implemented and how we maintain safety and ensuring controls are there in each place. We need to ensure that the OR directors that oversee the operations of the clinical space that you were making changes in is on board and comfortable. The anesthesia team, which through Dr. Calder's leadership and partnership is on board, because it involves a process flow more than a workload flow, just a process flow change for the anesthesia team. And then facilities, biomed, sustainability, to ensure that everything that we're doing to decommission the central nitrous oxide systems is done in a safe manner and done in a sequential operation that maintains all of our safety standards as well. And so once this rationale for the initiative and clinical engagement are established, there are three phases that I will now dive into. One is assessing the opportunity impact, opportunity, and risk, as we just talked about, and then establishing the portable supply inventory management and storage process for the smaller e-cylinders in a close by vicinity that makes the anesthesia team and the OR team comfortable with the change, that this is not going to be a huge change that is going to be coming their way, and then decommissioning the centrally pegged system as the last step in that process. So in assessing the impact, opportunity, risk, or throughout the entire initiative process, it is incredibly important to have designated roles and responsibilities amongst the teams or amongst the people involved. So we know what falls within our domain, what's in our control and what's out of our control, so that we can properly use the team members' skills and strengths to carry out the change and influence change within the organization. In our project structures, we started off with the OR director kind of giving us a sense of how much nitrous oxide is actually being used. Is nitrous oxide, as Dr. Collar mentioned, it is a low clinical potency gas, and so is it a popular, and this is between the OR director and the anesthesiologist, is it a popular choice of anesthetic gas, or are the clinicians practicing in that area moving towards the other bottled alternatives? And then we start off with an inventory and make and model number of the anesthesia machine. All of our machines in our cases have had, we've been lucky that we've had a port on the back of every anesthesia machine that we work with that has a port for e-cylinders to be hooked on directly to the machine. But there are some older models where there isn't a nitrous oxide e-cylinder port available on the back, and so that would be a good thing to verify as you're going through this evaluation. And then evaluating space constraints goes hand in hand between facility sustainability and then also the OR director. And we want to make sure that we're not going into sensitive spaces, or we are not taking up more space than what the OR team is comfortable with sharing to store any backup clinical use e-cylinders. And once we've gathered the clinical use data by location, by clinician in the Epic, from the Epic slicer dicer, and we determine the uses outside, of the OR uses. And so we start reaching out to people, all of our stakeholders, to kind of get buy-in on what we're trying to do. On the facility side, what we started off with is doing a wall outlet inventory, identifying going back to our medical gas distribution drawings and looking at all the locations where nitrous oxide is delivered, and then going into the rooms and getting an inventory for what type of ports are installed in that room. Some might be legacy installed a number of years back, and so we want to make sure that we have the right parts available when we do go to the decommissioning to actually blank off that wall ductwork. We are on the facility side. We are also responsible for gathering the procurement data for medical gas vendor by supply tank, and then of course calculating that data. Converting that data into greenhouse gas emissions, quantifying the percent loss rate, and then normalizing it to benchmark and gauge our opportunity. The next step then is establishing portable supply. And this transcends across all the three main groups leading this process as well. The first one is nitrous oxide cylinder management process, protocols, education. So in our case, in the ORs, after we've deployed or we've let the team know that there's an X amount of nitrous oxide e-cylinders closely available to the clinical end use location, as backup for if you need nitrous oxide. Here's working with them to define a process, documenting it, putting up the right signage to make sure that everyone is aware that nitrous oxide backup is available with e-cylinders. It is replaced at a frequent basis, and it can be provided on an as needed basis. And then working with the anesthesia technician team to understand the cylinder exchange workflow. To making sure that they know that full cylinders and empty cylinders go in separate spaces. They must be designated as such, and then working with our anesthesiologist and the biomed team, especially in making sure that our low pressure alarms on the system on the anesthesia machines have working displays, have the threshold and the volume defined, so that if we are ever at a point where our nitrous supply is running low, we know with ample time to actually replace the e-cylinders. And one of the big things that Dr. Kalra and the anesthesiologist team, technician team helped us with is to make sure that there's a behavior change in the use of nitrous oxide as well, which is that at the end of the day, if you are not if you're done using nitrous oxide and there are no more cases for the day, then you actually go ahead and turn off the valve on the machine so that we are not continuously in an open state for nitrous oxide, because when you have a local supply attached to the anesthesia machine, as soon as you turn it on, as soon as you turn it back on, you have the supply there. And then on the facility sustainability side, what I was responsible for is looking at storage locations and making sure that they are in compliance with all of our NFPA requirements and all of our other code requirements that I'll dive into a little bit further as well. And so once you have assess the impact and opportunity, and you have clinical buy-in, and you have established a portable work supply, you want to make sure that you've remapped any of the workflows that there might be a slightly higher frequency of replacement of e-cylinders due to the switch from backup to primary source of nitrous oxide. And so you want to talk about roles with end user for ordering the e-cylinders as needed and coordinating with the supply chain vendor team or the facilities biomed team to discuss who's going to switch out the cylinders if needed. In our case, the picture on the right shows our medical gas tank farm for our Palo Alto campus. And so as you can see, this hosts all of our e-cylinders and H tanks as well as backup storage. And what we have in our hospital is we have our vendor team, 2 people from our vendor team on site that are responsible for managing the inventory of this room and then transporting that to each of our end use locations in the hospital. And so really the point is to communicate to the end users that we have ample backup in our storage room down in the basement. If you need it closer to your end use at any point, we are giving you this storage space as well. We are giving you the storage space closer to your end use location to use as well. And then once we have that these processes defined, we come down to decommissioning the centralized system. And this is the process where it is utmost importance to ensure patient safety throughout the entire decommissioning process. And so we have to take clear and deliberate process steps and hard controls before hard controls are implemented. And so the first step that we took is implementing a Joint Commission standard risk assessment to make sure that we're looking at the whole picture holistically and capturing any and all risks that might be involved in the decommissioning process, and ensuring that we've communicated with all the right stakeholders, so that we don't go ahead and do something and then somebody is surprised by it at the end. And then once that is done, we did multiple site walks to capture our lockout tagout process for the centralized system. And then from there, it's really the lockout tagout process that is expanded in in the three following steps. So there's the supply side decommissioning, the demand side decommissioning in the rooms, and then the alarm decommissioning process. And so I'll dive a little bit deeper into that. The decommissioning of the central supply system requires disconnecting the system at the central manifold and tank farm and the individual zone distribution valves install and the zone isolation valves, and placing the right signage that designates that nitrous oxide line is not in use anymore. And that's shown by the pictures over here. And the red circles mark the key areas to focus on in each of these pictures. At the demand side, at the point of use, blank plates are installed for the wall outlets and the boom outlets on the anesthesia machine to complete decommissioning and ensuring patient safety. As you can see, there's different types of wall outlets that you could come across. So there's a wall outlet on the left and then a machine outlet on the right, both of which are shown to be blanked off in this picture. And then to complete the decommissioning, you want to make sure that all of your alarms are correctly configured so you don't turn off the central supply system and there's alarms going out all throughout the hospital. And so for that, working with your alarm vendor team to ensure that the central supply utility alarms are turned off or decommissioned. And then also I want to work with the biomed team on the anesthesia machine. As you can see on the picture on the right, there's a central supply line alarm and a cylinder alarm for the local supply. And you want to make sure that the nitrous oxide supply line alarm is turned off. And so with that, I'll kind of expand a little bit more into the pilot at 875 Blake Wilbur and show some more of our results, which happened from January 6th through January 27th, and how this all came about into place. As a background, nitrous oxide usage is distributed across 2 floors at 875 Blake Wilbur, which is the ambulatory surgical center. On the ground floor, we have an MRI scanner and an HDR suite with piped supply coming from a ground floor medical gas storage room, and that is using 8 cylinders. On the 3rd floor, we have operating rooms. We have 12 operating rooms, 3 interventional radiology rooms, and 2 procedure rooms. And this pipe supply is actually coming from the main campus tank farm, shown on the right in the picture over here, through these cryo tanks that you see in the picture. And similar considerations, as Dr. Kaldar mentioned, for our pilot and then for our decommissioning process. And so our process followed the same, our pilot execution followed the same process. We had the same OR director, anesthesiology, facility sustainability, biomed champion, and of course, hospital leadership buy-in. And then we went into a state of assessment, pilot, evaluating the pilot results, establishing the portable supply, and then decommissioning the central system. Prior to decommissioning, of course, the change was endorsed by our interventional platform leadership and communicated to the anesthesia faculty. And what we want to make sure really is that there's no impact to access to healthcare services or patient safety. Nitrous oxide is still going to be available. It is not going away. We are just changing in the background how we are providing nitrous oxide for the clinical end use. And that is, and so we have all the control measures of storage space, alarms, accessibility defined. And the workflow changes that then we want to communicate to our anesthesia faculty and our anesthesia technician team is that fresh gas flow from the E-cylinder must be switched off at the end of the day when not in use and turn on at the start of the day. And then in terms of how we manage the supply or the reordering, the lead anesthesia tech to order and switch out the E-cylinders as needed, and then either pulling facilities or your biomed team to agree to assist with installation in case of lack of available anesthesia techs. So we did this pilot at 875 Blake Wilbur over a period of 3 weeks, and the results accumulated across the 12 ORs, 3 interventional radiology rooms, and the procedure rooms accumulated as shown in the chart on the right. The green line shows the measured consumption in liters, after we weighed the cylinders every week and converted them from pounds to liters. And then the brown line is our true consumption of Epic data. And you can see that there's some slight errors, in between the two. Within the acceptable error range. So what we measured is about 2,400 liters, and what the Epic showed is about 2,800 liters. And the acceptable error range error propagated across all the rooms, across all the measurements that we took, was about plus or minus 809 liters. So we were still within our error range. But one thing of note that came about is, following this pilot structure, you have to really make sure that the communication is key across each stakeholders. Our bulk of our error came from week 1 measurements, and that showed that there is a massive improvement opportunity for change management, because what we saw when we went in the second week is that the central supply was reconnected to the anesthesia machines in some of the rooms. And so what we want to do is ensure that, or even cap off the supply side or the demand side in the room before we actually go in for the pilot. And what our pilot then yielded, and if you go back for reference, one e-cylinder is about 1,600 liters. And what the results show on the screen over here is that across 3 weeks of usage in about 15 or so operating rooms, we used about 2,400 liters, which is about 1.5 or so in terms of volume for 1.5 e-cylinders across over a month's time. And those results, ever since we've done this, have kind of maintained themselves at the rate at which we're using nitrous oxide, which shows that it is incredibly actually feasible to move from the central supply system to a portable supply system because of the low amount of clinical demand for nitrous oxide without any impact. And so, as I said, no cylinders were replaced at any anesthesia machine location during the 3 weeks of piloting. Now, coming down to emissions impact that we have realized so far, as Dr. Collar mentioned, we did 2 projects so far. We have Redwood City and 875 Lake Wilbur. And what we've seen so far over a year's period is about 827 metric tons of carbon dioxide emissions or reduced per year. And that is 95% of what we could have reduced in this scope. As shown in the bar chart on the left in the comparison, and this represents about now 197 gasoline-powered vehicles taken off the road. In terms of cost savings, as Dr. Collar also mentioned, it is relatively cheap gas, but there's still some cost savings involved. So, depending on how your organization looks at cost savings, you might consider this cost neutral, but there is some cost savings. So, in terms of the commodity cost, the doors, the doors of the cryogenic tanks are about $650 per. 8 cylinders are $215 per from the prices that we have, and then e-cylinders are about $35. And then total operating costs, including for delivery charges, hazmat, cylinder rent, change in consumption, and order frequency, we are seeing about $12,000 in savings from a system that was total costing about $14,000 per year to operate. And moving into next steps. As I mentioned, we've completed this at 2 locations, and now we are going forward into in the next couple of months doing our main Stanford Hospital 300 pasture before moving on to our newest hospital 500 peak. And here's some of the organization-wide considerations for new or ongoing projects that we've communicated and gotten executive endorsement for as in between this time. So ongoing and future projects can be categorized under 5 project status categories to determine project-specific recommendations for nitrous oxide decommissioning. So projects that are in planning, in early design, or in late design we are not including nitrous oxide piping in the design, and instead providing e-cylinder storage in the design. Projects that are too late in the game right now, so they might be in permitting or we're going on a case-by-case basis, discussing with our regulatory body to make sure that there's no permitting delays or certification delays to the projects before moving forward. And then in construction, if projects are already in construction, we're going to go as is and then decommission the location after certification. And we ran into a couple of code concerns, so I just want to quickly address that, and then I'll open it up for questions. There's been a lot of questions about whether providing backup storage close to clinical use raises any code concerns with the Joint Commission or with HCI, as we are in California as well. So I just want to cite over here three different sources that back up our information, our justification, back up our decision that it is not impacting any code requirements. NFPA 99, 2012, the CMS adopted version, says that individual small-sized A, B, D, or E size cylinders available for immediate use in patient care area shall not be considered in storage. And individual cylinder storage of 300 cubic feet, which is 12 e-cylinders in a space less than 22,500 square feet, shall not be required to be in enclosures. In addition, there's a CMS memorandum from 2007 that reiterates the same point, that says that any non-flammable medical gas in clinical settings is considered operational supply. And then a more California-specific code, you can refer to the HCI Freer manual from 2023 that provides recommendations on how to store nitrous oxide in medical gas storage rooms, or if you're using a storage room outside of that as well. And so with that, I will close it up, and I hope this session has been helpful for our attendees. And Troy, I'll turn it back over to you.
Perfect. Excellent. Thank you to both of our panelists for just an amazing presentation. Thank you. We have a few minutes for a couple of questions, so remember, use the Q&A function to place your questions in the chat. So first question, your presentation's attention to detail is very valuable. What percentage of nitrous oxide is not absorbed by the patient and exhaled? How is the exhalation of unabsorbed nitrous oxide captured, or does it escape to the atmosphere?
I'll take that. So first of all, nitrous oxide, we are trying to address the leakages happening from inefficient delivery of nitrous oxide. Whatever nitrous oxide is actually delivered on patient care is actually going to be eliminated back into the environment. But that number will be less than 9.5% of the total nitrous oxide used when we are using a system which is extremely inefficient, like a centralized cryogenic tank system or the compressor cylinders. To answer your questions, nitrous oxide is not metabolized within the body. It is used to induce anesthetics, and when it is exhaled out, it is taken away by the scavenging systems within the OR to minimize any OR pollution, but eventually all those scavenging systems are actually venting it out into the atmosphere. So yes, so nitrous oxide is venting out into the atmosphere, but that number will be far less than the current system of using centralized cryogenic tank system or the compressor cylinders.
Great, perfect. Thank you, Dr. Kalra. So the next question that came in via the Q&A function, was the transition to e-cylinders in labor and delivery unique compared to other ORs?
I can take this question. So we are on the adult side of the hospital, and we haven't encountered personally any labor and delivery locations where we've carried this out at, but I'm very closely partnering with our Stanford Children's team as well. And what I'm from what I know about their process, there isn't anything unique about those locations as well, because it is merely what we're saying is that we're just changing the method of supply for nitrous oxide. We're not encouraging any change on how or who or when is using nitrous oxide.
Excellent. Thank you for that answer. I'm going to throw in a question here. Some may hear this presentation and think, wow, it's Stanford medicine with a deep academic tradition and a large facility. And so I want to ask you to highlight what portions of your journey are repeatable by smaller facilities. And so the first question here is, how do you find a Dr. Cholera, a clinician champion? And if you don't immediately see one in your organization, is there a way that you can cultivate a relationship to make this journey possible?
I think at some levels, these issues becomes personal. If you believe in the process, if you believe in this problem that GS climate change is happening, most of the healthcare providers, everyone wants to do the right thing for their patients. Unfortunately, there's a lack of awareness among healthcare providers how their own actions impact or contribute to climate change. So as an anesthesiologist, when I learned about that anesthetic gases are greenhouse gases, it honestly bothered me. It bothered me to the extent that, something that was never being taught to us when we were doing a residency or our training, 25, 30 years back. So, and again, to be fair, a lot of literature also came out in the last 10 to 20 years as well. So once you start reading about it, you feel convinced that if, I need to educate other folks, because in order for me to change the culture or bring a new culture of sustainability, I have to educate people. The only way you can bring change is through connect, convey, and convince. And connecting with the audience requires making a passionate plea, providing them the latest evidence, whatever is out there, and then trying to create and convince them that this is something good for the institutions. We are all on the same team trying to do the right thing for our patients. So our first project was challenging in a way that it took us a little bit longer time. But once people start seeing a value in it, then it becomes easy to be adopted. So for example, the first product we did was on removing desflurans from our ORs. Practice Green Health provides us a sort of a report card, as I showed earlier. And in that report card, by eliminating desflurane from our ORs, we were able to show 83% reduction in the carbon emissions coming from fluorinated anesthetic gases. That number in itself was a huge, that the biggest outlier was desflurane out of all those 3 fluorinated anesthetic agents. And by simply making one simple change, that this anesthetic gas, we can actually provide safe anesthetic care without using this anesthetic gas in a clean, sustainable manner, we can do that. And when the results showed up, everyone was so impressed with these findings, and that motivated people to, okay, you know what, now let's try to do something else. Then of course nitrous oxide came into our journey, and we are really happy and that we are able to at least decommission nitrous oxide into our projects. So I would say success is really contagious. Once you start getting it, you want to have more of it. And there are plenty of opportunities in healthcare to bring changes in the system.
Excellent. That is an excellent answer. I have one more question that's in the chat. I'll ask you to give a one-sentence answer. What's next in Stanford's journey in sustainability? What's next?
Sadat, do you want to answer that?
Yeah, sure. The next thing is to carry out these nitrous oxide decommissioning across all of our major hospital locations. And then the biggest thing that we're focusing on is our transition off of natural gas and electrify as many systems as possible to move towards a vision for an all-electric hospital and an all-electric healthcare delivery system that provides resilience in the system as well.
Excellent. Well, I just have to say thank you so much for just a really precise presentation that I think will be an inspiration to all of those on the webinar. Just quickly as we close, I want to announce our next Bending the Climate Curve lecture. It's exploring the clinician's role in decarbonization with Dr. Amy Collins and Dr. Jonathan Slutzman. It's November 19th. We hope that you will be able to join us and that you'll be able to share this with your clinical friends as well, so that other organizations can be inspired to take steps like Dr. Cholera and Mr. Khan have taken. Thank you so much to our panelists, to all of you. Have a great rest of your day, and we hope to see you next month. The link for the next webinar is in the chat momentarily. All right, thank you, everyone. I'll leave it on just for a moment so you can grab that link for the chat.
Thank you, Troy. Thank you, Mazzetti, for the opportunity, and thank you for listening.
Yes, of course. Thank you for all the inspiring work that you're doing. Take care, everyone.